Good afternoon, everyone, and welcome to today's webinar, Paying for Quality, What is the Impact on Health Equity? This webinar is brought to you by the Health IT Policy Subproject of the Transdisciplinary Collaborative Center for Health Disparities Research at Morehouse School of Medicine. I am Megan Douglas, Associate Project Director for Health IT Policy, and we are partnering today with the Health Equity Leadership and Exchange Network, or HELEN, and the Georgia High Tech. Thank you everyone for being here. We're really excited about the content. The Health IT Policy Center of the TCC has two primary focuses. We are looking at research to inform policy about the impact of health IT and public policies on health disparities, and we also have a practice focus. We work with community organizations to implement the health IT policies that we've studied to advance health equity in practice. Couple of housekeeping notes. All participant microphones are muted. If you have any technical issues, please use the tech support chat pod on the right side of your screen. We do not have a call-in phone number, but we will be recording this webinar and archiving it on our website for anyone who isn't able to catch it today. If you have questions for the presenters, please use the presenter chat pod also on the right side of your screen. We will be stopping periodically to ask some poll questions. And if we have time at the end, we're hoping to have some question and answer and discussion, but we do have a lot of content to get through today. So if we run out of time, we will have continued dialogue in the TCC virtual learning community. And in addition, the Helen has started a discussion forum that you can also engage around this content. The TCC virtual learning community is available at the link on your screen, and we will provide these instructions at the end of the webinar and also in the post-webinar email. So I'm not going to spend time on this right now, but we'll guide you through that at the end. The TCC is funded by the National Institute on Minority Health and Health Disparities. This is our funding disclosure. And just a short overview of the webinar. We are going to provide some background on the MACRA legislation from which these proposed rules come from that we'll be talking about. We will talk about the health equity implications of the proposed rules. As I mentioned, hopefully have some time for discussion, and then we'll talk about the timeline and key dates. And if we run out of time for discussion, please submit your questions. We will answer those questions in the NCPC virtual community and in the Helen forum. So this proposed rule was almost 1,000 pages long. We are actually still in the process of sorting some of it out, as I'm sure a lot of you are too. So we're really looking forward to your feedback today on some of these issues. We are focusing solely on health equity, so we're not going to cover the program specifics or general practice implications today, but we will talk about the directly mentioned health equity provisions, which health equity is mentioned 14 times in the proposed rule, primarily in the clinical practice improvement activities section. And then there are a lot of indirect implications within the proposed rule, and we will discuss some of them as well. We are really honored today to have some really excellent presenters. We have Daniel Dawes, author of 150 Years of Obamacare, which was just published. He is the Executive Director for Health Policy and External Affairs at Morehouse School of Medicine. And then we also have Dr. Marshall Chin with University of Chicago, the Richard Perillo Family Professorship in Healthcare Ethics. So at this point, I'm going to hand it over to Daniel so we can get started.
Thank you so much, Megan, and good afternoon to everyone. Good morning to our friends on the West Coast. I want to thank you for joining us for this critical discussion, specifically on equity and quality. You know, as we move toward a health reform system that's tying clinician payments to quality, it's important for us to understand the implications, the impact on health equity, right? And why is this important? Because there is a fundamental difference between improving healthcare versus reducing and eliminating health disparities. So here is a slide to show why we're concerned. What exactly is going on here? We know that disparities in quality and outcomes by socioeconomic status, race and ethnicity, etc., are large and persistent and were not through 2012 improving substantially. Those aren't my words, those are according to the Agency for Healthcare Research and Quality. And what this slide is showing, what these two different maps are showing, is the difference between quality and disparities across the United States. On the left side of your screen, when you look at healthcare quality, one of the things that it shows is that, mostly northern states and Midwestern states have the highest quality scores. And then in the South, we tend to have lower quality scores. If you look on the right side, what's interesting about that is that the states that tend to have higher quality scores also have the highest disparities among racial and ethnic groups, versus in the South, where the disparities are not as high, except, of course, with Florida, Mississippi, Alabama, and Louisiana as the exceptions there. So the concern is that as we're pushing for improving the quality of healthcare in our country, there is a real possibility that this may exacerbate disparities in healthcare. Now, as many of us might remember, almost 2 decades ago, the Surgeon General and the Institute of Medicine, now the National Academy of Medicine, and I want to thank Karen Anderson for her leadership there, released 4 landmark reports. And it was interesting because these reports actually brought to light the fragmentation in the mental health services arena and then in the general healthcare arena. And what these reports actually highlighted was there was a critical need to address the underlying disparities as we were trying to work to improve these systems. Now, when you look at the Institute of Medicine's Crossing the Quality Chasm report, they actually identified 6 key components of quality. And as you can imagine, as you've guessed, equity was a key component of that. But it's often the most neglected when we are talking about improving quality. And so what does that equity component entail? It really entails providing care that shouldn't vary in quality because of personal characteristics such as gender, ethnicity, geographic location, disability status, and socioeconomic status. And for many of us, you might recall during the negotiations around the Affordable Care Act back in 2009, 2010, when we were trying to push a health equity agenda in the Affordable Care Act, that there was this national working group. And many of you, I know, were involved in this, of course, led by the American Psychological Association there in D.C. And this group came out with 5 principles to push an equity agenda in the ACA. And that time, we actually took these reports that were produced almost 10 years earlier, and we recognized that we had to also get folks to recognize that as we are looking at quality improvement, as we're looking at these pay-for-performance policies, they must take into account the needs and challenges of populations that have traditionally suffered health disparities and barriers to health services, right? And we've got to work to reduce them. So we wanted folks, as they're really pushing these delivery and payment system reforms in the Affordable Care Act, we wanted them to take a look at how they actually exacerbate disparities oftentimes if we don't utilize an equity lens. So with the health reform law, we know we were successful. Obviously, there were 62 provisions, health equity related provisions that we got into the law. And there was one in particular, though, that deals specifically with these delivery and payment system reforms through the National Quality Strategy. And we saw an opportunity to say, if you are doing anything, United States Health and Human Services Department, CMS, if any of you are doing policy around delivery and payment system reforms and you're driving and aggressively pushing for these quality improvements, well then you've got to also address the intersection of equity. That 6th category, that 6th critical aim of quality, or else we'll never realize a more accessible, equitable, and person-centered health system in the United States. So as we all know, ARA set the American Recovery and Reinvestment Act, that stimulus law, was really the foundation for a lot of these reforms that were promulgated by the Affordable Care Act. And interestingly enough, after the ACA, there was a special report by Health Affairs highlighting the incredible health equity agenda in this Affordable Care Act. But there was one article in there that raised some concerns, and it was that we were not paying attention after the ACA passed in terms of addressing this issue of quality and equity. It was neglected when the National Quality Strategy came out. No real mention there. There was no strategy that came out looking at this. Nothing from CMS really focusing their attention on this issue and at least helping us to understand that they understood the concern. So last year, Secretary Burwell in January 2015 came out with this huge announcement that she was going to aggressively push fee-for-service payments towards value and tie them to quality as we move forward. And we've seen that HHS actually has met that goal for 2016, tying 30% fee-for-service payments now to different alternative payment models, such as bundled payments, accountable care organizations, et cetera. And 3 months after that, though, the Congress actually came out and they passed the Medicare Access and CHIP Reauthorization Act. We supported that, and it was huge because they actually reauthorized all of these health equity related provisions in the Affordable Care Act that were slated to be sunset. And thankfully, they did reauthorize them. They did push to extend, though, these health reforms, these delivery and payment system reforms. And that's when we recognize, gee, if Congress is now pushing more aggressively, HHS is pushing, we've now got to raise our voices and raise awareness of these issues, or else many safety net providers, many of us that serve the poorest and sickest patients, disparate populations, could be in significant trouble. So MACRA comes, it passes, and it's a game-changing law in this space for us. So even if you're not in the quality improvement space, if you are a public health person, if you look at population health, if you're looking at the social determinants of health, this law, this proposed rule actually has opportunities for us to address. So there are certain challenges that it presents in terms of quality and equity, but there are also opportunities for us to advance equity in America. And so I want to turn it over to Dr. Chin, who is going to help us to understand at the ground level just how we can take advantage of this and how we can utilize this knowledge using this lens to inform this proposed rule as we move forward. So Dr. Chin, the floor is yours.
Thanks, Daniel. Thank you very much.
Sure.
So Daniel asked me to speak about how to achieve health equity in clinical performance measures. And by clinical performance measures, we mean the standard quality metrics that Medicare has required in its quality programs. So measures such as blood pressure control, or use of evidence-based medications for asthma, or prevention of hospital readmissions. Here are my disclosures. So there's a movie from 1940 that's called The Story of Dr. Ehrlich's Magic Bullet. Dr. Paul Ehrlich was a physician and scientist in Germany, and his life work was trying to find cures or magic bullets for infectious disease. And in fact, he found the magic bullet for syphilis was a compound called salvarsan. However, the startling secret of the magic bullet for health equity is there is no magic bullet for health equity. So, for example, what will work for reducing disparities in my South Side, predominantly African-American population may or may not work in Los Angeles or Memphis or New York City. But at the same time, it's not like we're just wandering in the wilderness, that we do know a fair bit about what can improve equity, and in fact there are magic bullets, plural, for health equity. What makes it both rewarding and challenging is that it's both a process for what to do to approach reducing disparities, models of care that might be adapted then, and of course then tailoring to your own specific context. One of the pieces of good news, though, is that there's growing consensus on what the right approach is to caring for vulnerable populations and achieving health equity. We run a Robert Wood Johnson Foundation program called Finding Answers over the past 12 years, which has worked on achieving equity, and we've developed a roadmap to reduce disparities. And about a couple months ago, the National Academy of Medicine came out with the report at the left here, Systems Practices for the Care of Socially At-Risk Populations, which have many similarities. And in fact, there's referencing of a lot of our work in the National Academy of Medicine report. In 2012, in the Journal of Internal Medicine, we published an article that reviews 6 steps of this roadmap. At the very bottom of the slide, you see our website, www.solvingdisparities.org. And so you go to that website and download this article for free. In some ways, step number 6 is like an overall umbrella for the roadmap, making equity an integral part of quality. In other words, it's seamless and, as Daniel was talking about, sort of inseparable from quality. It's not a marginalized event like doing a community event or a one-time health equity project, but it's embedding equity into all we do with quality of care. So I'll spend the rest of my time talking about that, as in particular then steps 4, 5, and 6 of this roadmap. So first, a couple points about elements that a lot of people tend to concentrate on, which are helpful but insufficient alone. And that's cultural competency training and stratified performance data being part of the solution, but not the whole solution. And by stratified performance data, I mean taking quality measures and then stratifying by factors such as the race, ethnicity of a patient, or their socioeconomic status. These are all helpful, but what is critical is changing the structure and system of care. That is equally or more important than cultural competency training and stratified performance data. What the evidence shows is that stratified performance data, feeding that back to providers and health organizations, and cultural competency training, they raise awareness and improve readiness to improve, but they do not improve the traditional clinical performance measures that we're talking about, for example, with the Medicare program and MACRA. I think a lot of organizations, they think about equity and they say, well, part of the solution is cultural competency training. It clearly is, but they tend to get fixated upon that. Similarly, early on, a lot of organizations, they spend a lot of time trying to develop the health information technology to create stratified performance data reports, which again is very important, but those two alone don't really address a lot of the fundamental systems problems and structural problems that drive equity. So those two are important, but alone aren't enough. So then I'll talk a little bit now about 4, 5, and 6 here, designing, implementing, and sustaining interventions, which start to get at issues of both cultural competency, but then some of the fundamental systems and structural problems driving inequity. So this 4th step is design and intervention. I'll talk mostly about root causes, 6 levels of influence. Another one that's important too that I want to talk about is learning from your peers, that seeing successful peers and learning from their experience. So root cause analysis is sort of common sense, that you see a disparity in your particular patient population, and then you figure out, well, what's driving it. What I want to point out here is that for any type of patient-centered outcome, there is no substitute for talking to patients. In particular, you can't use other folks, such as minority providers, as a proxy for minority patients. But one example is that one of our grantees from this Robert Wood Johnson program was the Medicaid health plan. And they were looking at trying to reduce their Latino disparities for depression, where their Latino patients were doing worse than their white patients. They talked to their Latino doctors and nurses and educators who suggested a phone counseling intervention. So it turns out they had trouble enrolling more than like a dozen patients across the health plan. And one of the major reasons was the cell phone use. And it turned out that most of the patients had cell phone plans that was a paid by the minute plan, whereas most of the providers have the unlimited plan use. So with the paid by the minute plans, it was a major financial potential hit for the patients, and so they weren't able to do it. My guess is that they talked to a number of patients in focus groups, they would have uncovered that problem from the beginning. Our conceptual model for interventions to reduce disparities is again sort of common sense, but it reminds us where there may be 6 different levels of targets for interventions. Left-hand side of this diagram, you have a person who is living in a community. If they have access to care, they become a patient interacting with the healthcare provider within a healthcare organization. Above that, you have the policy superstructure, the big hammer being financing, which we'll talk about with MACRA. And ultimately, at the bottom of the diagram, you are influencing the processes of care, the outcomes, the traditional clinical quality metrics. So using the example of children with asthma, I'll just go through like 6 different levels to give you a flavor of what we're talking about as the different types of interventions at different levels. So a policy level intervention would be, how can you create policies and resource allocations to promote clean air, reduce exposure to secondhand smoke, and a non-allergenic housing environment for children. For the healthcare organization, can you prevent emergency department visits and readmissions by increasing access to primary care by things such as extended hours of the clinic? The microsystem is the immediate care team. So, for example, can you embed community health workers into your basic team to support home-based asthma management? For providers, one example would be train providers in culturally appropriate motivational interviewing to promote self-management of patients. A patient family example would be, can you use email or text messaging to receive real-time advice for parents on handling severe asthma exacerbations? A community example would be school-based screening programs to screen for asthma in student athletes. So again, it's a reminder that it's multi-level, the different areas for potential intervention. So one of the sobering pieces of findings is that there's not a lot of common themes for what successfully reduces disparities. We reviewed about 400 disparity intervention articles. The best we could come up with were these 6. So the first one, as we've been talking about, multifactorial interventions that attack these different levers causing these disparities. Culturally tailored quality improvement approaches better than generic one-size-fits-all approaches. Good evidence for team-based care, especially nurse-led care. I think what's going on here is that these teams, if they can closely monitor patients both in the healthcare setting as well as at home, and there can be that regular checkup, well, then that can be a very effective element for chronic care management. Not surprisingly, involving families and communities and non-health partners in the solutions. All patient navigators or promotors or community health workers, a lot of good evidence for that. And then interactive skills training. So as opposed to like a didactic lecture, interactive skills training, for example, demonstrating how to use an inhaler for asthma can be effective. So the 5th is implementation, sort of a whole field of its own. And here is just to sort of point out that what good business managers know, that you have to think about the overall organization and setting and tailor to that particular context. So, for example, your intervention, you think about the magic bullet, well, why is it better than the status quo? But beyond the intervention itself, what is the environment? So, for example, the audit environment, what are the external incentives that would lead someone to either do or not do your intervention? What's the culture of your institution? What are the beliefs? I just came back from a meeting a couple days ago at the University of Chicago where the diversity team was getting feedback, and 3 nurses gave some really important feedback saying that, well, we see a lot of initiatives over the years, regardless of it's equity or quality or whatnot, some of which there's long-term commitment to, others which really are just, the intervention of the month. So, what's to make nurses believe that, well, this equity initiative that we're going to do really is for the long term. So it has to get to do with that culture, the history, the beliefs of the nurses. And then what's your process for intervention, the planning, the executing, the evaluation of the effort? It comes down to behavior change, that when we're talking about either changing the behavior of patients or quality improvement, we're trying to change behavior of healthcare providers or organizations. It's all behavior change. And I think that rapidly we all realize how complicated it is. Initially we're taught, well, it's education, that we just affect people's beliefs and knowledge. We tell people, well, why they should be doing things. Well, that's the answer. But then we realize, well, that's not the way the world works. That education is important, but again, usually insufficient. And we can say, well, we're all social beings, that we're part of organizations, we're part of communities, and so partly it's social norms, the culture. We've got to change the culture. And then there are incentives, so the environmental factors. So, for example, financial incentives. And then we learn of the psychologists here that, well, the self-efficacy or confidence, that if we're more confident we can do something, we're more apt to be able to do it. So that's where coaching comes in, teaching people how to do an intervention or how to change. There's this important factor here. We talk about motivation, divided into both intrinsic motivation, meaning professionalism, doing things for the right reason, or extrinsic, that we're having more and more attention to pay performance and financial incentives and extrinsic incentives. What's known at this time is that probably both are important, that intrinsic motivation is critical, but unless there's a financial case, it's hard to sustain things. Similarly, financial incentives can help, but if you sap away people's intrinsic motivation, it's really self-defeating. It can only incentivize so many different things. So really, some mix of the two is probably the most effective. So the last thing I'll talk about is sustaining the intervention, and here's where we start dovetailing with the broader topic of this, MACRA and payment and equity. So the things that we've been talking about, it's a lot involved in transforming an organization to be really good at improving equity, probably at least a 5-year process, probably longer. As we talked about, it involves culture change, buying in at all levels, training in diversity and cultural competence, and training in quality improvement. recruiting and retaining a diverse workforce. Very importantly, reorganizing the structures and systems of care to meet all patients' needs, doing the financial modeling to make the numbers work for the business case, and then there's accountability. How do you basically sort of put decreasing disparities, increasing equity into the incentive structure for the people at your organization? So why make the effort to achieve health equity? It goes back to that slide a couple moments ago. It's the intrinsic motivation. It's the right thing to do. And then, and this is now relatively new, the financial models are starting to align. So, I know we have a lot of the believers here on this particular webinar that have been working on equity for a long time, but the good news is that the financial models are starting to align, so it's going to be easier and easier for us to make the business case to the others in our organization that are working on a strategic plan for our organizations. So I'll mention a number of different things here as, before handing it off back to the larger discussion about MACRA. So even this year, Medicare is going to be starting for some of the programs to require public reporting for stratified disparities data, so the stratified performance data. They're increasing incentives for prevention and primary care. So Daniel's going to talk a little bit about like ACOs and the alternative payment model programs segment for the MACRA programs, which get into the incentives. Then if you have global payments and shared savings plans, there's more incentive for doing preventive care and for investing in primary care. There's increasing interest in so-called intersectoral partnerships. Intersectoral meaning combining healthcare with non-traditionally healthcare sectors such as housing or crime, criminal justice, or education. So you've seen probably the recent Medicare announcement for a call for proposals for accountable health communities, which trying to encourage these partnerships. Increasingly, we're going to see programs that will actually pay for reducing disparities. And my guess is that over the next 2 or 3 years, we're going to start to see equity accountability measures being built into payment programs. There's movements to start aligning potentially various measures, including equity measures, across public and private payers, creating more incentive for health organizations to work on these issues if the metrics affect a large percentage of the patients. And then for those of you working on the safety net, there will need to be specific things done to take care of the safety net. One that I know Dan will talk a little bit later is a risk adjustment. So for example, risk adjustment for the patient's socio-demographic status. So safety net organizations aren't penalized for taking care of tougher patients. And the need for more demonstration projects. The bottom line is that there needs to be an explicit equity lens so that we think about improving equity in all we do with quality. I'll end with this quote, which I've learned, both locally in Chicago, but then as we've worked with a lot of places across the country, it really matters. Leadership matters. It's our professional responsibility as clinicians, administrators, and policymakers to improve the way we can deliver care to diverse patients. We can do better. And it really does take individual champions. And so everyone here on this webinar really has a crucial role in being a champion, both at your own organization and then nationally, as we look to improve equity across the country. Turn it back to Daniel and Megan now.
Okay, thank you, Dr. Chen. And I'll pick up from where you left out, where you talked about the financial models starting to align with these opportunities, and I think they do provide opportunities for us to address health inequities in the system. So going to go through, as Megan mentioned earlier, we don't have a lot of time to go through everything, but wanted to start with this slide. So folks say, well, how is it presently and what do we have to look forward to, right? So under our current volume-based system, it's obviously a fee-for-service system, and the more the provider sees in terms of patients and the services that are performed, the increase in revenue that he or she is given. Under this proposed rule, under MACRA, it's a value-based system, right? So we want to reward folks on how healthy they're keeping, the clinicians, how healthy they're keeping their patients. And the payments to providers are going to vary based on factors like quality measures, whether the clinician has met certain quality measures, whether they participated in an alternative payment model. They're going to look at resource use or the cost per beneficiary in the Medicare system, and then of course their clinical practice improvements, and we'll talk about those as well. So payments are going to be linked to quality and value, and they're going to increase or decrease with performance. It is a budget neutral policy. So what is MACRA really? It ended the sustainable growth rate, that doc fix issue that we were hearing about, where there were potential cuts of 20+% cuts in Medicare for physicians. And it actually replaced it with this new system that we're going to talk about. It also creates a new framework for rewarding quality, and it streamlines or it combines existing quality reporting programs into one new system. And then, like we mentioned earlier, it reauthorized many of the health equity related provisions in the Affordable Care Act, which we were pleased. So as you all know, we have the proposed rule now. We've been waiting for this, and it was published officially on May 9, 2016. It was released about a week or two before that on April 27. And we are urging you to comment and provide comments, because I understand the folks at CMS are very interested in knowing how this law could either negatively impact or positively impact with the proposed rule in terms of vulnerable populations. So very, very interested, and public comments are due June 27, 2016. So what this rule has proposed is a quality payment program. And it's really divided them up into two tracks. This merit-based incentive payments programs, MIPS, and there you see the programs that combine the PQRS, the value modifier or value-based purchasing system, and then meaningful use. And then on the right side, you see the advanced alternative payment models. So this is where they're going to move aggressively towards ACOs, but not the track 1. So what does that mean? Tracks 2 and 3, these are ones with more risk. So you're going to have to take on more than minimal risk as you move forward if you get into this one. But today I'm really going to focus on the merit-based incentive programs. And here's why. So under MIPS, and like I said, this is a budget neutral policy. And what this means is that there are going to be winners and losers. And we could see in the beginning, plus or minus 4% in terms of your Medicare reimbursement, and that will increase to about 9%. So there's a potential to get a bonus of 9 or more % in 2022 and beyond. Now, CMS is estimating that roughly 95% of clinicians will participate in this quality track, MIPS, and only about 5% will participate in the APMs. And of the 5% that participate in APMs, they're only looking at about 60% of those getting a bonus. So what does this all mean in terms of QPP? Currently, it only affects Medicare payments, but it's likely to expand to Medicaid and private payers, to all payers in about 2 years. It is budget neutral. Like I mentioned, there will be winners and losers, so equal amounts of money for enhanced payments for high quality and penalties for low quality or low performing physicians or clinicians. And that is actually why we're doing this webinar. There's some issue with that because a lot of the safety net providers stand to lose, or clinicians that serve disparate populations would probably lose the most under such a system. And we want to make sure that these folks get it just right. And then, of course, there's the MIPS composite performance scores going to be available on Physician Compare. So this is why we want folks to pay attention to it. Because, again, we don't want there to be the separate on an equal system of clinicians. So who exactly are these eligible clinicians under MIPS? Well, folks under Medicare Part B that get Medicare Part B funding. So what they've done is to include physicians, DOs, MDs, dentists, physician assistants are included, nurse practitioners, clinical nurse specialists, and CRNAs. Not subject to MIPS are those clinicians that are in their first year of taking Medicare Part B, those clinicians that have less than $10,000 in claims for Medicare reimbursement and see fewer than 100 Medicare patients per year. In addition to that, hospitals and advanced APMs are also exempted from this. And the way folks can actually report out is individually or in groups. And that, of course, depends on the preference for the practice. So how is this whole MIPS program going to be scored? What actually goes into the score, right? The payment's based on performance in 4 categories: quality, resource use or cost, clinical practice improvement activities, CPIA, and advancing care information, which is formerly the meaningful use program. And under the system, in case you're interested, here's how, by law, according to the MACRA statute, this is how they're going to weight the different categories. Quality gets 50%, cost 10%, CPIA or clinical practice improvement activities is 15%, and advancing care information is 25%. And in case you're interested in seeing how they're going to allocate points and the potential points that you can get for each category, there they are on your right side. And if you're interested in knowing how they're going to continue to weight this as years continue, you'll notice that quality decreases to 30% by 2021. Resource use actually increases, so that's the costs. They're really going to drive down costs with that piece, and that's going to be weighted at 30%. But CPIA and advancing care information are going to stay the same. They can be changed after 2021, though, and that's why we want to ask you all later on whether you believe those weights should be changed or should they stay the same, should they change it one way versus the other. So let's talk about the clinical practice improvement activity, CPIA. And the reason why we want to focus on this one is perhaps because it really is the main category that addresses health inequities and actually is incentivizing folks to address this. Under the CPIA activity, you have 90 plus proposed activities that you can choose from, right? And they actually get certain credits. So you could choose 6 at 10 points each. You can choose 3 at 20 points each. If you operate a patient-centered medical home, you get full credit and you can move on. If you are in a accountable care organization, you do bundle payments, etc., you would then be able to get half credit as an APM participant. And again, the weight here is that it's 15%. So this is a new category for many folks who are in the Meaningful Use program. They might be interested in knowing how they can take advantage of these opportunities. So how does this actually works? Again, they're 10 points or 20 points, and you can actually do, and they're actually high weighted versus medium weighted again, so you have to look at those. But the exceptions to this now are very interesting. They have small groups, rural providers or clinicians, health professional shortage area clinicians, and all they would have to do is just choose 2 versus 3 or 6 of these CPIA categories, and they're scored at 30 points each. So very pleased that they at least took that into consideration, but there are some issues, though, that we're looking at in terms of the regulators surveying higher performing small groups, rural clinicians, and HBSA clinicians, instead of looking at also surveying the average and lower performing clinicians, because these folks are the ones that tend to serve the poor and sicker patients. Again, nationally accredited PCMH will automatically be given the highest potential score, so opportunities for folks there to check that box. And what CMS is actually proposing is that they want to look at a study of CPIA. They actually want to figure out how they can enforce this, because CMS actually believes that this might be the one area that folks can game the system. They think it's too easily gamed, and it would require a lot of oversight on their part, and they just can't do this. And that's why they've only given it 15%. And as time moves on, it would be the lowest percentage allocation to a category. So we'd love to hear your comments on that as we move forward. So here are the activities, the required activities under CPIA. They're going to look at expanded access, population management, care coordination, beneficiary engagement, patient safety, and practice assessment. And there are also proposed additional activities here that they're interested in looking at. Achieving health equity was one of them, integrated behavioral health and mental health, and emergency preparedness and response. So these are folks who are in the military. They are interested in hearing whether they should also include folks who have done that type of service. So I see a poll going up. Megan, do you want to explain that?
Sure. So the poll is related to the slide that we have up right now. As Daniel mentioned, these categories, achieving health equity and integrated behavioral and mental health, we know would have a huge impact on advancing health equity, but they are merely being proposed by CMS. So our poll question is, should achieving health equity and integrated behavioral health care be adopted as CPIA subcategories? We'll give you a few minutes as Daniel finishes out this issue.
Thank you so much. So in terms of achieving health equity, here's what they're looking at. They're going to give certain categories. So one category under that or subcategory would be seeing Medicaid patients, and they would score that as a high. If there is screening for the social determinants of health, or they also develop programs, these are clinicians developing programs to improve health disparities, those are scored at medium. So we'd be interested in hearing, is that appropriate? Should they be all high? Should one be medium versus high? So interesting issues there. And then with integrated behavioral and mental health, they are looking at proposing diabetes screening for people with schizophrenia or bipolar diseases who are using antipsychotic medication, and the list goes on. So let me continue here with this slide on clinical practice improvement initiatives, achieving health equity. Here are some additional ones. You'll see that there's really just one that is scored high, and that's seeing Medicaid patients in a timely manner. And then in terms of the other categories, you get a sense of all of those are scored as medium. And I'd like to hear your opinions as to whether that should change. So CMS is also seeking comment on the inclusion of two additional subcategories. So promoting health equity and continuity in social and community involvement. And you get a sense of what they're talking about there. So one is under promoting health equity and continuity, serving Medicaid beneficiaries, including individuals who are duly eligible for Medicaid and Medicare, accepting new Medicaid beneficiaries, participating in the network of plans in the federally facilitated marketplace or state exchanges, and maintaining adequate equipment and other accommodations, for example, wheelchair access, accessible exam tables, lifts, scales, etc., to provide comprehensive care for patients with disabilities. Also would be interested in hearing your views there, because these, again, are ones that they are proposing for future consideration. Should they be future, or should they actually be included in the final rule? And if so, I think a lot of those, as many of you might recall, align with the ACA's data collection and reporting system. So let's move on to the CPA opportunities for public comment, right? So in all, under this section, we think that it will help us achieve health equity and integrated behavioral health care, and that they should be adopted as CPIA subcategories, not just proposed. Is the CPIA percentage of CPS appropriate, a composite score? Is that appropriate, 15%, even though it is by law? After 2021, we would have an opportunity to ask them to increase that. Should it be, and why? And then, of course, there are targeted approaches to reducing disparities that are needed. Is that the case? Should any measures be reported by specific patient demographic or disparity factor? Are there additional activities that should be included as CPIA? Are the individual weights appropriate? Should any activities designated as medium be elevated to high, or vice versa? And are considerations for small rural HPSA providers sufficient to level the playing field? So you see the categories there. We'd love to hear your comments as we move forward. So let's move on to the category that is being scored the highest, 50%. So under this category, clinicians will have the opportunity to select 6 measures. And of course, here they will have to select either one outcome measure or another high priority measure. So these 6 clinical measures, we talked one outcome, one cross-cutting, and then there are also 2 to 3 population-based measures. And then they'll give a bonus for high priority measures. So those are outcome, appropriate use, efficiency, care coordination, patient safety, patient experience. Should they also have to include as a high priority measure under quality health equity? We'd love to hear your comments. And if so, what should that look like?
Daniel, we have another poll question up for this. So the question is, how should health equity be incorporated into the quality performance category? Stratification of current clinical quality measures by a disparity variable, a standalone health equity clinical quality measure, both A and B, or health equity should not be incorporated into the quality performance category. So we will leave that poll up for a few minutes to assess your answers, and Daniel, go ahead.
All right, thank you, Megan. So let's talk about resource use very quickly. This is the one that is scored at 10% in the first year, but then it will increase in subsequent years to about 30%. And this is where they're going to look at Medicare spending per beneficiary. So there are two basic measures for this. Looking at the Medicare spending per beneficiary, they're going to look at the cost of hospitalization to prevent a readmission. So they're going to look at 3 days prior to the hospitalization and then 30 days after the procedure. And this is really getting at that issue of high readmissions, which they believe equals high costs. And also the fact that they also believe that if you are a clinician and you have low readmissions, then that means it also equates to lower costs. So that's that first piece of this. The other aspect is looking at total per capita cost. They're going to look at the cost per year per patient for all the procedures that you perform on this individual patient. And there is no additional reporting that is required here. The measures are going to be calculated using claims. So once you submit your claim, CMS is going to take care of the rest. So let's get quickly into this advancing care information. What exactly does this mean? So it really is the replacement for meaningful use. It's no longer an all or nothing approach. So MIPS actually has changed this to be a more flexible approach, okay? And the way that they're going to determine this overall composite score is through a base score and a performance score, both weighted equally about 50%. So the base score is really looking at, did you at least submit or report information about all the measures and standards? And there is this rule, this requirement that if you fail to do a security analysis to protect health information, you automatically fail. And you will get 0 points for that aspect. For the performance score, this is where now they're looking at how did you further the objectives or measures. For instance, did the patient download or view their health record? And here it's interesting because the refined focus for the performance score looks at patient electronic access, coordination of care through patient engagement, and of course health information exchange. How are you utilizing that? And then for those who are interested in knowing who the MIPS eligible clinician are for this aspect, they're looking at physician assistant, nurse practitioners, clinical nurse specialists, CRNAs, and hospital EPs. And this is interesting because they're actually allowing these clinicians that are mentioned to submit a waiver, to exempt an exemption form if they believe that this doesn't because they were never allowed in this program, they would get an exemption from having to meet this actual category. So, but they would have to submit the report to do so. Should that be allowed? Should we actually expand and require additional health professionals, psychologists, social workers, etc., to be among this group, especially as we're pushing for interdisciplinary collaboration among the different health professions? And in case you're interested, these are the 6 objectives for the base score that they will be measured on: protecting patient health information, which we talked about, e-prescribing, patient electronic access, coordination of care through patient engagement, HIE, and then, of course, public health and clinical data registry reporting. Now, in meaningful use, there was a hardship exemption for clinicians who serve, lower socioeconomic status patients. Here, they talk about, they've recognized that they had that hardship exemption in this proposed rule, and we know that was for insufficient internet connectivity. Oftentimes, we find that vulnerable populations, disparate groups, don't have access to that internet connection. Extreme and uncontrollable circumstances, God forbid there's a hurricane or a natural disaster, lack of control over availability of an electronic health record, and lack of face-to-face patient interaction. So there used to be that hardship exemption, and now what CMS is proposing is to re-weight that category to 0. So they're not necessarily allowing the hardship exemption, but they will give a 0, and they're going to ask you to, they'll take that percentage and apply to another category, such as quality, for instance. So, you know, folks don't really get out of it. Even though you might have a hardship, no, you're still going to have to meet these MIPS categories, or they're going to raise the weight for another category that you're going to have to weight. So no real hardship exemption here for these individuals. In terms of the health equity implications of health IT, we know that primary care and primary care electronic health adoption disparities really apply for small, rural, and high Medicaid providers. We have seen that there's a lack of health information exchange or interoperability, especially for these groups of clinicians. And there have been challenges with patient engagement through patient portals, patient-reported data. And this is really interesting because as this is weighted 25%, we are concerned that providers that serve these disparate populations actually would be penalized, because a lot of this is going to require some level of patient involvement, and it's very hard oftentimes to get these patients to actually access the database or access their medical record, et cetera. So interested in hearing your thoughts. Do you agree or disagree with that? Should we comment? And then there is an expectation for physicians to engage patients even outside the clinical settings, right? So especially patients with higher burdens of social determinants of health, we need to start addressing that within the ACI category. So opportunities for public comment here. Is the proposed framework sufficiently streamlined to improve adoption rates by providers serving underserved communities? We know that hospitals have done very well, about 90% or higher in terms of becoming meaningful users. So adopting health information technology and becoming meaningful users of this technology. But clinicians, and these are primarily physicians, are really between 30 to 40% meaningful users. So they're way behind hospitals in this. And then if we include additional health professionals, clinicians, they are also going to have challenges that they have to take care of in that respect. So something to think of there. Are there additional hardships that should be added to the list? We'd be interested in hearing your thoughts there. And additional resources needed to accomplish these proposed objectives. So want to really finish out this piece with risk adjustment. Very hot topic. As many of us know, it's a very contentious area, and CMS has been very wary, HHS as a whole has been wary of masking the disparities among different population groups. So the thought is that it's insufficient. Risk adjustment is insufficient to even the playing field for small and rural practices and clinicians serving high Medicaid, high disparity populations. We currently risk adjust for clinical factors, such as, if you have a very sick patient, but we don't do for socioeconomic status. And we know that folks deem SES as a proxy for disparities in underserved populations. We know ASPE, the Office of the Assistant Secretary for Planning and Evaluation, is conducting a study looking at this, and they should have a report out by October of this year. So very interested in seeing what they determine with that report. But as we move forward, we wanted to highlight 3 alternative approaches to risk adjusting, and we'd love to get your thoughts on these. One is spatial stratification. It controls for regional and geographic variation in outcomes. Would that be one option that we could push? Size stratification compares small practices to small practices, large systems to large systems, and safety net to safety net providers. So basically comparing apples to apples and oranges to oranges there. And then the third issue that we wanted to also get feedback from is this notion of penalties, or at least allocating a portion thereof and redistributing those to the lower performing eligible clinicians in the form of grants, so that they can improve. They can use that funding that they lost. They can compete for it. They can then use that to actually bolster their efforts where they're weakest. So the health equity takeaways as we close this webinar, really the positives is, as Dr. Chin and as Megan alluded, is that there are very robust health equity provisions, integrated behavioral health provisions in the CPIA performance category. They're pretty comprehensive, so we're quite pleased with that. But do we need to go beyond that? Do we need to strengthen them? and differentiate the weights. There's a bonus point for patient experiences in the quality performance category. We love that. There's also a relaxed requirement for small, rural, and HPSA providers. Should it be relaxed more? Should we do something differently there? And then there's streamlining of advancing care information, that meaningful use performance category. Anything there that you all think we should be looking at. But we're pleased so far that they've at least allowed for a flexible approach for our providers, our clinicians. And then there is also the expansion of advancing care information performance category to additional providers. We're pleased, but does it go far enough? Do we need to include these behavioral health providers, psychologists, social workers, counselors, etc.? And of course, again, the flexibility to choose metrics most appropriate to each practice. We do appreciate that. But should there also be a requirement then that all practices, regardless of their size, regardless of their geographic distribution, that they should have to look at this issue. They should be compelled to look at health equity and how it impacts different vulnerable populations across their communities. The negatives is the lack of health equity metrics, of course, in the quality performance category. We believe that if you're going to address this issue of equity and quality and tie so much of our payments now to quality, and we know that, you know, the IOM and other groups have said that equity is a key component of quality. Should there not be an equity metrics within that quality performance category? There's also the insufficient weight that's given to CPIA performance category. Is 15%, are we being fair, is 15% insufficient, or is it sufficient? Should it be more? Then there's the risk stratification. The risk stratification fails to even the playing field. So we wanted to hear your thoughts on the risk adjustment, those three pieces that we talked about. And then, of course, whether you know, the average or low performing small rural HPSA providers, whether they should also have their voices heard, and whether consideration should be addressed, well, whether they should take into consideration their unique needs, not just the higher performing small rural and HPSA providers. And of course, again, this is a complex regulatory structure we had previously, and it's replaced by a different complex regulatory structure. So I'm going to actually stop here and let Megan take over.
Thank you, Daniel. You flew through a lot of that information. I expect that we will have questions and comments from the audience, and I hope that we do. We have had a few questions and comments throughout, a couple of comments that we received for the participating in an exchange plan. Someone pointed out that that in many states is not up to the providers, but is actually up to the health plans themselves. So offering that as one of those high priority measures in the CPIA categories may not be one that many providers have a whole lot of control over. So we would definitely encourage that comment to go into any public comments, and you know, I think that's an important point. Another comment, just to give some specifics around how some of the disparity variables would be incorporated into the clinical quality measures. Each clinic would have the opportunity to define the disparity metric depending on the populations that they see in the clinic. So they could stratify those clinical quality measures by gender, age, rurality, race and ethnicity, and have the flexibility to cater those disparity variables to the populations that they're seeing in the clinic. We had another question about how someone would pay for this, and I'm thinking that is from the physician perspective of how you would pay for implementing some of these programs, and I'm going to hand it over to you, Daniel, after I just mentioned kind of shifting that focus. This isn't a voluntary or optional program anymore. This is how payment, this is what your payment as physicians is dependent on, is complying with some of these regulatory structures. You have a lot of flexibility in choosing those, but it's not something that providers can just ignore. Daniel, your thoughts and comments on any of those issues.
Absolutely, and it actually goes back to what Dr. Chin was saying when he talked about the financial opportunities there, finally aligning with these health equity programs and principles that we've been advancing now. So I'm actually pleased that we're now requiring it because
Daniel, you're really low. Can you speak louder into the microphone?
Sure. Can you hear me now?
Yeah, that's much better. Thank you.
Okay, sorry about that. So I was saying that it really goes back to what Dr. Chin was saying when he talked about the financial incentives finally aligning. So I'm very pleased with the CMS Administrator, Andy Slavitt, and our champions, health equity champions at CMS, who have been pushing this notion and recognizing that, you know what, unless we require this, oftentimes folks won't even pay attention. And this really is an effort to get folks to recognize that, yes, we do need better quality of care. That's clear. But at the same time, as we are moving towards that, we need folks to recognize that you can't just push for improving quality without addressing equity, because it will exacerbate the disparities among these different vulnerable populations.
Great. So thank you, Daniel. We encourage you to continue submitting your questions through the Helen discussion forum. This link on your slide should be active, so you should be able to access the forum directly from this link. And then, again, the TCC virtual learning community, this link should be active as well. You will have to set up a profile within our learning management system if you're not already a member. You will select the Groups tab and then the Workspaces, and we have a TCC Public Comments for Health Equity workspace that you'll see. We are happy to walk anyone through that process that may need help as well. We will have the slides posted there. We will have the proposed rule itself, and we're developing resources to hopefully make some of these specific components a little bit more digestible, smaller chunks, and trying to translate them in a way for how will this impact my practice, because we really want to, again, encourage your voices to be heard. It's critical to this process, and we hope that you will participate with that. Thank you, everyone, for being here. We appreciate your engagement and sticking around for a couple of extra minutes. And have a good afternoon.